Chapter 34, Care of a Patient with Disorders of the Urinary System. Lesson 34.1, Care of Patients with Disorders of the Urinary System Theory Objectives. Examine the signs and symptoms of selected urologic inflammatory disorders like cystitis, urethritis, and pyelonephritis, and nursing interventions for these patients. Explain nursing management for patients with acute or chronic glomerulonephritis. Analyze types of patients' conditions that create a risk for acute renal failure, ARF. Compare the needs of patients on long term hemodialysis with patients who use peritoneal dialysis. Identify the benefits and special problems associated with kidney transplantation. Clinical practice objectives. Describe the postoperative nursing care of patients having surgery of the kidney. List specific nursing responsibilities in the care of patients with kidney stones. Provide the postoperative nursing care of patients having surgery for urinary diversion. Perform interventions to increase patient compliance in the treatment of chronic kidney failure. And devise or revise a nursing care plan for the home care patient with renal failure. So, cystitis, what is it? Etiology and pathophysiology. Well, cystitis is an inflammation or infection in the female urethra alongside um, bladder infection, cystitis. So this can be caused by E. coli primarily. Infection of the urethra is urethritis. Inflammation or infection of the bladder is cystitis. Honeymoon cystitis is something, it's a nickname that we've given a particular type of cystitis. Oftentimes, young women would get married and then go on their honeymoon and then come home with a bladder infection. And this is just a hygiene practice that we don't teach well enough to our female patients. And that is that they need to urinate after intercourse and just to make sure that they take really good care of their feminine hygiene. The estrogen depletion that occurs with aging also results in structural atrophy, which can cause urinary dysfunction and urinary stasis. We do have estrogen creams that the doctor prescribes to these patients that they can apply topically to help increase the tissue. Cystitis signs and symptoms. Well, there's painful urination, also frequent and urgent urination, and low back pain associated with cystitis. Also, cystitis is a very recurrent disorder. It occurs often. Less acute symptoms like fatigue, anorexia, and a constant feeling of having a full bladder or some bladder pressure between flare-ups um, can indicate that there is a tendency for recurrence. Older adults and confusion. When older adults get a bladder infection or any UTI or urinary tract infection for that matter, they have cloudy urine. They may also have hematuria or blood in their urine and signs and symptoms of infection. But one thing that we see that's very different in the elderly population is that they have extreme and sudden confusion. In order to diagnose cystitis, we need to do a urinalysis and a urine culture to determine what bacteria has caused it and to confirm that we have, in fact, an infection. Confusion is one of those first signs of cystitis, remember, in your older adults. Treatment and nursing management of cystitis. Well, antibiotics is going to be your big one because this is a bacterial infection. We also can provide topical estrogen cream to postmenopausal women in order to help uh, make their tissues stronger and maybe less susceptible to bacterial infection. We encourage fluids, 8 to 12 large glasses of water unless contraindicated, in order to flush the urinary tract system. Cranberry helps to alter the pH. The bacteria is uncomfortable living there, and therefore cranberry juice or cranberry azio supplements are ordered occasionally. Sitz bath and hot water bottles can ease any discomfort caused by the cystitis. It's very important that we provide lots of education about how to prevent urinary tract infections to our patients. Vitamin C is also a good preventative. Urethritis. So, this is inflammation or infection of the urethra. This can be caused by gonococcus or herpes viruses, so STDs. It also can be non-specific urethritis. So, maybe something we're not sure exactly why it's inflamed. Childbirth can also cause urethritis. Obviously, we have a lot of um, bacteria during the time of childbirth and a lot of trauma, and then chemical irritation. So using various feminine hygiene projects or products or soap in the area can cause inflammation. Burning, itching, frequency and voiding, and painful urination are going to be your signs and symptoms of urethritis. Also, there may be a purulent discharge if the patient has gonorrhea. We say the urinary meatus actually becomes swollen and inflamed and reddened, and inserting a Foley catheter in these patients is quite painful for them. They are very sensitive. Diagnosis of urethritis. Well, first of all, we're going to consider the signs and symptoms of your patient. Also, a possible patient history that may include possible exposure to sexually transmitted infection. Culture and sensitivity of the urine are going to be obtained in order to identify what organism or bacteria is causing the issue. And culture specimens will be used to rule out STIs as well. Treatment of urethritis and nursing management, very similar to cystitis. We'll give them antibiotics. However, the nurse should be especially aware of the possibility of a gonorrheal infection until we have a definite diagnosis. And we should carry out important teaching to prevent spreading the infection to the eyes, which can cause blindness. Moving on to a different infection. So we talked about cystitis and urethritis. Now we're going to talk about pyelonephritis. So pyelonephritis is infection or inflammation of the kidney. Acute pyelonephritis can be caused um, or can cause stasis of urine, but also can be caused by stasis of urine. So not emptying the bladder fully, urinary retention. Chronic infection actually causes scarring within the kidneys themselves. So the acute state of pyelonephritis, we see fever, chills, headache, malaise, nausea, vomiting, and flank pain that radiates to the thigh and genitalia. Chronic pyelo, we see subtle and gradual scarring. They end up losing weight, can keep a low grade fever, and are chronically weak. How do we diagnose pyelonephritis? Well, first of all, they're going to have signs and symptoms. So we're going to do an H&P, and the doctor will do a physical exam. Urinary culture and sensitivity will alert us to what type of organism is causing the pyelo. And then we may also do a KUB, or kidneys, ureter, bladder radiography, and potentially even intravenous pyelogram to check for obstruction. Obstruction could cause a backup of urine and therefore infection or inflammation of the kidney as well. Treatment of pyelonephritis. Well, we need to quickly treat and prevent recurrence. If there's an obstruction, we need to correct it by removing the stone and preventing future formation. If it is an infection, we want to treat with antibiotics. Sulfonamides like Bactrim or fluoroquinolone like Cipro are effective against gram-positive and negative bacteria. So they're often started first for these kind of infections. Put the patient on bed rest, treat the pain, and treat the fever with antipyretics. Okay, moving on to acute glomerulonephritis. So this is an infection or inflammation in the kidney inside that glomerulus, which is where we have that crossover of blood and filtration, right? The afferent and efferent arteriole come into form the glomerulus. So we've got inflammation or infection within that area. What can cause this? So most commonly, this is caused by a streptococcal infection, beta hemolytic to be specific. Strep throat can actually move to your kidneys in the form of glomerulonephritis. So it's very important that you treat streptococcus wherever we find it within the body so it doesn't move to the kidneys through the blood. In the immune system, there's an antigen antibody reaction as well that can cause glomerulonephritis. So that's a second cause of this acute glomerulonephritis. These patients are going to have sudden fever, chills, flank pain, edema, puffiness around their eyes, and potentially visual disturbances, and also marked hypertension. Urinalysis, creatinine, and BUN will clue us in to see if there's a infectious organism causing this, and also if it's impacting kidney function. That's why we're checking the BUN and creat. We'll also do a CBC to look for elevated white blood cell count. The urine's going to be smoky, cola colored, and will be positive for red blood cells, protein, and have an increased specific gravity. So, this is one of those causes of brown urine, acute glomerulonephritis. Treatment of acute glomerulonephritis includes initial therapy with IV medications. We give methylprednisolone, steroid, in order to decrease inflammation, and cyclophosphamide. Sodium restricted diets and fluid therapy are important because the kidneys are already going to be stressed. We want low protein, high carb diets, um, and they may even have to go through plasmapheresis if there's an autoimmune disorder to hopefully eliminate that reaction between the antibodies. Nursing management of acute glomerulonephritis will get a very thorough clinical history. Also assess for edema. Edema can result in cardiac failure and pulmonary edema. So, for retaining fluids, it's very important that we are on high alert for that and we let the doctor know to get some new orders. Put the patient on bed rest and maintain bed rest until the hematuria, proteinuria, and hypertension subside. Also, maintaining that sodium restriction, administering antihypertensives and diuretics, possibly assisting with the plasmapheresis process, and administering the corticosteroids to reduce inflammation and the immune response. We also may want to take a look at their shunt if one is placed in order to make sure everything looks good with it and that care is provided. And then monitor your patient for complications. One of the common complications is that edema. Unfortunately, when we have edema or third spacing, it can also result in swelling in the brain. So it's important that we're often checking mental status for indications of increased intracranial pressure. Chronic glomerulonephritis, it can be rapidly developing or it can progress slowly. So this is either boat, right? It could also be caused by kidney atrophy, which is decreased function of the nephrons, and eventually renal failure due to increased blood pressure or a host of other things. These patients have generalized edema, headache, often associated with their high blood pressure, fatigue, dyspnea or difficulty breathing, weight loss, loss of strength, increasing irritability, and nocturia or urinating at night. We'll also see protein and blood in their urine, and they'll be going through the process of kidney failure, and their labs will reflect that. They may have acute exacerbations where they get worse. Chronic glomerulonephritis is the third leading cause of chronic kidney disease and eventually kidney failure. Diagnosis of chronic glomerulonephritis, well, we're going to do examination. One of the things we're going to look for is retinal hemorrhage. Retinal hemorrhage would indicate that there is high blood pressure and it's uncontrolled, and therefore would clue us into that this is a chronic glomerulonephritis issue. Urinalysis, creatinine, BUN, CBC, and electrolytes will also be checked to check for potential pathological causes. Additionally, the function of the kidneys and how well they're doing, and see how that's impacting reabsorption and fluid and electrolyte balance. Proteinuria, urinary casts, elevated BUN and creats, anemia, hyperkalemia, magnesemia, increased phosphorus, decreased serum calcium, and decreased albumin are noted with chronic glomerulonephritis. So lots of lab work. How do we treat it? Well, in the latent stage, it's just going to be treating the symptoms, unfortunately. Dialysis and kidney transplant are really, once we're in those last stages of chronic glomerulonephritis, are our only options. So figure out a different way to filter their blood and potentially replace the organ. Nephrotic syndrome. So this is a different, so we're moving on. This is a different disorder of the urinary system. We see proteinuria, hyperlipidemia, hypoalbuminemia, and severe edema, especially facial edema. Around the eyes or paraorbital edema may be present in the morning. Lower extremity edema is more evident at the end of the day. These patients are very irritable, tired, and lethargic. What do we look for to diagnose them with nephrotic syndrome? Well, we do a urinalysis and serum test for proteins and lipids. We also would do a renal biopsy. Adequate protein, low fat, low sodium diets can be very important for these patients, including supplemental vitamins and minerals. Diuretics, antibiotics, cortisone to decrease inflammation, and cyclophosphamide may be given. We need to monitor their INO very closely and record their daily weights, encourage rest and provide skincare, and encourage compliance with the dietary medication regimen that the doctor has ordered. Hydronephrosis. Moving on to a different condition. This is dilation of the renal pelvis and ureters due to some kind of obstruction. So we have fluid on the kidney. Hydro means fluid, nephro means kidney. It also could be compensatory. We also will have compensatory hypertrophy or the growth of the kidney due to the dilation. This may be unilateral or bilateral, depending on where the obstruction is. There may be severe pain and signs of kidney failure with hydronephrosis. Urologic exam and detailed radiographs will help us to diagnose it. So they'll put in a nephrostomy tube or a ureteral stent to drain the fluid off of the kidney. The primary goal is to remove the obstruction so the kidney may drain properly, though. So we may end up going in and doing a stone removal or some kind of lithotripsy to remove the stone. Nursing management of hydronephrosis. So post-op care, hemorrhage and dressing are going to be, we're looking for hemorrhage. It's a big deal, right? We want to make sure that we're dressing the area and making sure that it's intact and dry. We also want to be positioning the patient and encouraging coughing and deep breathing. We want to focus on promoting that unimpeded urine flow by properly caring for all catheters and tubes, including that nephrostomy tube, because if we cause a kink in those or potentially a clog, then we're just going to be um, proliferating the issue or exacerbating the issue. Renal stenosis. So, renal stenosis is a blocked or narrowed renal artery. Hypertension happens when you have stenosis, right? So, if the renal artery is narrowed, you're going to have a higher pressure coming into the kidney, and therefore, we're going to have lots of kidney damage. This is going to lead to chronic renal failure, and also those with chronic renal failure are at increased risk for renal stenosis. So, it's kind of a correlation regardless. MRI, magnetic resonance imaging, computed tomography or CT scanning, ultrasonography are going to show a decreased kidney size, which is going to be indicative of that renal stenosis, not getting enough blood flow to the kidney. Antihypertensives can be given to decrease the blood flow. We may do some balloon angioplasty in order to open up that artery to provide improved perfusion. We also may place a stent in that renal artery. Renal stones. So, renal staghorn calculus are pretty common renal stones that we see. Variations in composition and there are variations in composition and environment. So, depending on if you have an acidic environment or alkalinic environment, you may have different types of stones. There are many different types of renal stones. So, if you don't mind me just briefly going through them, they're going to depend on their cause and what they look like. They're going to have um, different appearances and also different etiologies. So there are many different types of renal stones, one of which is called a carbapatite stone. There are several different types of those, three different types, in fact. These are caused by having a high level of calcium in the urine, potentially even UTI. If there's other crystalline species or uh, an increased carbonation rate, right, of calcium phosphates, we may see the formation of the carbapatite um, stones. Also, they may be inherited or acquired, specifically that the distal renal tubule is more acidotic. Sjögren's syndrome and chronic hepatitis can also cause these kinds of stones. Urinary tract infection, hypercalciuria, and primary hyperparathyroidism, which is going to increase the level of calcium in the blood, are going to be causes for other types of the carbapatites or the type 4Bs. You also have struvite stones. These are caused by urinary tract infection by urea splitting bacteria. These are very um, uh, poofy, I guess, in nature. So we do see those with UTIs. And then we have brushite stones. These are very spiky stones. They're caused by hypercalciuria, primary hyperparathyroidism, having a phosphate leak, medullary sponge, kidney. We see a lot of these with high calcium levels in the blood. So it's important that we identify the cause and the type, that we do preventative measures based on the type, and that there's some kind of appropriate method of treatment depending on the type. There are also stones caused by increased uric acid, which can also be hereditary. So those uric acid stones are usually with a low urine pH. Stasis due to like prostatic hypertrophy. These are the kind we see in the older male adults. Um, we also may see these in metabolic syndromes as well. Other uric acid stones can be caused by insulin resistance or type 2 diabetes or having a low urine pH. Ammonium hydrogen urate stones can be caused by hyperuricosuriia, neutral or alkaline urine pH, and then also by UTI, urea splitting microorganisms. And then ammonium hydrogen urate stones are caused by chronic diarrhea, electrolyte imbalance or alkalinic imbalance, high urate concentration, low phosphate intake, and laxative abuse. So there are a world of stones caused by many different issues. Positive factors for stones in general. So we just discussed lots of them, but do know that bariatric surgery can be a cause of stones, also short bowel syndrome and other conditions that decrease the oxalate absorption in the gut. Okay, so bariatric surgery, short bowel syndrome, anything that's going to reduce absorption is going to potentially cause renal stones. Additionally, inadequate fluid intake, which results in concentrated urine and inadequate flushing of the urinary tract, can result in stones. Urinary stasis or sluggish flow of urine, as may occur with bed rest or immobility, puts a patient at risk for increased risk for formation of stones. And then diabetes, obesity, gout, and hypertension put them at risk for those uric acid stones. So we already talked about some of these. Calcium oxalate are your most common stones. You also have those calcium phosphate, uric acid, struvite, and cysteine stones. Renal stones, cause and pathophysiology. Well, calcium stones are really common and they're caused by a parathyroid tumor or increased production of calcium, increased serum calcium. Being a male, having a family history, being immobile, or having history of recurrent UTI will put you at increased risk for renal stones. How do you prevent stones? Well, adequate flow of dilute urine through the kidney is going to help wash out any small stones that are forming and therefore prevent enlargement. Also prevent UTI because we do know UTI can cause stone formation. Urinary pH modification using things like ascorbic acid or any kind of dietary modifications can increase the acidity and therefore prevent the calcification inside of the renal system or the urinary system. Ideally, adults need to put out at least 2,500 milliliters of urine every 24 hours to prevent stone formation. Likewise, preventing urinary infections and maintaining adequate drainage through the tubes and catheters is also necessary. Signs and symptoms, these are going to be severely painful for your patients, especially stones that are small enough to move along. They may end up displacing, but they also might move from a area where there's more dilatation, or there's more room into a smaller area, and that would become extremely painful. Flake pain, which is down the sides of the abdomen, may radiate toward the genitalia and inner thigh. This causes obstruction and swelling of the ureter, and therefore there's lots and lots of pain, right? Nausea and vomiting may occur as well, oftentimes just due to the pain itself. Moving stones can get trapped in the ureter, causing obstruction of flow and swelling of the ureter and potentially even the kidney itself. So how do we diagnose this? Well, we'll do urinalysis. We'll also do a KUB to see if we can identify the stone. We also might do an intravenous pyelogram so that we're actually looking at the kidneys, the ureters, etc. Serum levels of uh, calcium, uric acid, and cysteine may enable us to know if there's a stone. And so with that IVP2, it's a special kind of X-ray that provides images of the urinary tract. So the urinary tract is made up of your kidneys and your ureters, etc. So we're looking at those on that X-ray. Hey, treatment for renal stones. Well, the first thing we're going to try to do is flush the stone out with conservative management. Oral intake, increasing that, increasing intravenous infusion. That way we have lots of fluid that could potentially flush that stone. We'll want to make sure that we're straining the urine in order to identify the stone once it's passed. Pain management is going to be a big thing here. We can give opioids, NSAIDs, antispasmodics to decrease pain. We also may want to administer antibiotics, right, to decrease the risk of infection. or to treat infection that has occurred as a result of renal stone. Irrigation via urethral catheter or percutaneous nephrostomy may be used, where we're actually injecting fluid and withdrawing. Stent placement in order to allow the dilation of the ureter so that the stone can pass through. We also may do an ESWL or extracorporeal shockwave lithotripsy, where we're using a laser to actually break up the stone into little pieces so that it's able to pass easier. And then cystoscopy and surgery. This is where we're actually going to visualize it and remove it if we can. Nursing management for renal stones, a big thing is going to be our pain management, increasing the fluid intake to 3 to 4 liters per day, early ambulation, adjunctive therapy for going through an ESWL like corticosteroids, calcium channel blockers, and alpha agonists. Percussion, diuresis, and inversion therapy may be used in order to um, uh, remove the stone, right? And this might be something that you're definitely part of. Cystoscopy or surgery like a nephrolithotomy, pilolithotomy or uterolithotomy, where we're going in and actually removing the stone itself. Monitor for signs and symptoms of infection, hemorrhage, obviously, as we are working with really narrow passageways, and leakage of fluid. Initial assessment, we need to be watching for changes in urinary output, characteristics of the urine, risk factors, and the thorough patient history, and getting other assessment data. Straining of urine, like I said, is going to be very important in order to identify if the stone has been passed. Attempts are made to have the patient pass the stone spontaneously, and all urine is strained to recover the stone or fragments so that it can be analyzed. So, what about trauma to the kidney and ureters? Well, blunt trauma from things like motor vehicle accidents, sports, or occupational um, or occupational injuries can cause blunt trauma. And then you have penetrating injuries. So these are the injuries that actually go into the kidney, or ureteral trauma, right? Minor contusions can cause that swelling, right? We might see some swelling. Also, there may be hemorrhage or bleeding from the kidney or ureters. This is considered a severe hemorrhage and has to be treated because these patients are going to be at increased risk for hypovolemic shock or losing volume. Okay, signs and symptoms and diagnosis of trauma to the kidneys and ureters. We may see massive hemorrhage and blood in the urine, abdominal or flank pain, possibly an enlarged mass in the abdomen or a rigid belly, right? Diagnostic tests, we're going to do a urinalysis, NH&H, electrolytes, BUN, and creat to see the functioning of the kidneys, potentially radiologic studies like a KUB, IVP, or CT scan to figure out what's going on anatomically. Patient is also at risk for rhabdomyolysis, so we're going to be looking at indications of that, and also acute renal failure, right? Hourly measurements of urinary output and observations of the characteristics of urine are going to help to determine the type and the extent of the injury to the kidney. Bleeding is often self-limiting, so we don't usually have to intervene unless we're replacing volume. Lacerations and contusions without renal function interruption, as long as you don't have a increasing BUN and creat, we'll just put those patients on bed rest until it's resolved. Severe kidney damage, we may have to go in and actually resect the kidney through a nephrectomy. Preoperative care, we want to monitor for hypovolemic shock, any kind of cardiovascular or circulatory system changes. Make sure we're monitoring closely their urinary output and the size of their flank mass. We may have a gray Turner sign. This is where we have bruising over the flank or lower back that's suggestive of retroperitoneal bleeding. So if we have that gray Turner sign, we know we're at increased risk for massive hemorrhage of the kidney. We're going to be monitoring urinary output and indwelling urinary catheter. Postoperatively, we're going to be also managing or monitoring their output, managing their pain, and watching for continued signs and symptoms of hypovolemic shock. Trauma to the bladder. So causes of this can be a violent blow or crush injury that's causing a bladder perforation or rupture. Bladder trauma is more likely to occur if the bladder is full. So it's important that we keep that bladder empty, and especially before procedures. Painful hematuria or blood in the urine that is ouchy, or the inability to void is going to be a sign and symptom of trauma to the bladder. There's going to be marked tenderness, potentially even spasm in suprapubic areas, and a large mass or that is expanding, potentially even a rigid abdomen that becomes board-like. Diagnosis is going to be made on gross hematuria or blood in the urine, suprapubic pain and difficulty voiding. We may do retrograde or CT cystography in order to diagnose a rupture or perf. Suprapubic cystostomy is indicated if the bladder has ruptured or is perforated. Meticulous attention to drains and dressings are going to be very important after trauma to the bladder for the nurse. Also, cold applications to reduce inflammation. Postoperative shock and massive hemorrhage are a possibility, so be on the lookout for changes in the circulatory system or cardiovascular system, and be ready to alert the doctor to any changes. Cancer of the bladder. So, cancer of the bladder causes smokers are at high risk for bladder cancer. So, just know that smoking is a huge risk factor for bladder cancer. Also, urban living, occupational exposure to nitrates, dyes, rubber, or leather processing, all of those toxins and pathogens, right? And then bladder papilloma tumors can also develop. These are highly invasive and they metastasize very quickly. It's estimated that approximately 80,000 new cases of bladder cancer will be diagnosed in 2019. It will result in death for 13,000 men and 4,800 women. Signs and symptoms and diagnosis of cancer of the bladder. These people are going to have blood in their urine, frequency, urgency, or dysuria. We may do an IVP, cystoscopy, or biopsy of a tumor in order to diagnose cancer of the bladder. Complementary and alternative therapy. We want to just make sure that we're maintaining a healthy bladder, right? These people might end up getting bladder injections. They may end up getting pain management depending on the extent of their cancer. How do we treat it? Surgery, chemo and radiation, cystectomy or transurethral resection of the bladder tumor. We see this a lot. Is done. We look for bleeding afterwards. These patients are usually put on irrigation following. Intravesical chemo is also used to treat this, and Bacillus-Guerin or BCG installations can work to kill the cancer from within the bladder. Photodynamic therapy may also be used. Urinary diversion. So there's a minor and a major surgery for urinary diversion. We're either going to do both kidneys or one kidney. We'll either bring them together or have them separate. Urinary diversion and bladder removal may be necessary if there is trauma to the bladder that is substantial, or if there's bladder cancer, the bladder is no longer going to be functioning properly. So we can use the ileal conduit or the ileal loop. We may do a cutaneous or through the skin ureterostomy, where we bring the ureters out to a stoma, either one stoma or two stomas, depending on how it's diverted. They also might do a vesicostomy, ureter sigmoidoscopy, or a sigmoid conduit, an ileal reservoir, a Koch's pouch, Indiana, mains, or Florida patch. And then there also may be orthotic bladder substitutes that can be implanted. So these are all different types of urinary diversion. Also, after cystectomy, there's always the danger of hemorrhage and infection, right? So here are some examples of ureterostomies that are diverting urine directly to the skin surface through that ureteral opening or the stoma. After ureterostomy, the client must wear a pouch in order to collect that, right? So cutaneous ureterostomy, just like a simple one with one kidney, would result in one stoma. They also may connect a ureter of one to the ureter of the other, so they drain from the same stoma, or do a bilateral cutaneous ureterostomy. So that is a possibility as well. Urinary diversion procedures are used to treat bladder cancer, but also any kind of massive trauma to the bladder that cannot be repaired. Here's another example of urinary diversion. This is an ileal conduit or Bricker's conduit or a colon conduit. This is where the conduits collect urine in the portion of the intestine, which is then opened onto the skin surface as a stoma. So after we create this conduit, of course, we must wear a pouch. So we're draining it actually into a portion of the intestine and draining it from the intestine. Sigmoidostomies, like this ureter sigmoidostomy or the ureteral ileal sigmoidostomy, are going to divert urine to the large intestine so that no stoma is required. And that way, both your urine and your fecal products are going to be coming through the rectum and then anus. So the client will excrete urine with the bowel movements directly into the toilet or the bedpan, and bowel incontinence may result just because there's so much fluid there, right? And then a fourth option for urinary diversion is this continent, internal ileal reservoir, or a Koch pouch. Ileal reservoirs are going to divert urine into a surgically created pouch or pocket that function as a bladder. So it's going to theoretically do the same thing a bladder would do, as in that it stores urine. However, there's no way, it's not connected to our urethra, so there's no way to excrete it. So what do? The stoma will be continent, and the client would self-cath the actual stoma in order to drain urine off. Nursing management, clarify orders regarding the irrigation of the tubes, drains, or stomas. Make sure that you know how to properly care for those. Postoperative care, observe for pain, abdominal rigidity, fever, bleeding. Urine should never stop flowing regardless of the surgical procedure. Urine color and characteristics will be important to document. Stoma assessment and skin irritation around the stoma site will be important to document. And then we're going to work to reduce odor of urine, right? So that it's more psychosocially supportive for the patient, and then provide that psychological care as well as they're adjusting to a new, potentially altered body image. Cancer of the kidney. So risk factors for kidney cancer is smoking and exposure to lead or phosphate. These patients may have blood in their urine, a palpable abdominal or flank mass, potentially flank pain as well. They may have fever, fatigue, weight loss, decreased appetite, or high blood pressure. We'll do a renal angiogram, arteriogram to look at the blood vessels, CT, MRI, and ultrasonography to diagnose cancer of the kidney. How do we treat cancer of the kidney? Well, we surgically remove the affected kidney through a nephrectomy before metastasis occurs. We don't want that cancer to spread throughout the body, and therefore we're going to resect. The patient usually does not have severe symptoms until metastasis has occurred. Chemo with a variety of drug regimens is used for metastatic cancer. They may use Sutent or Nexavar. They're drugs used for advanced kidney cancer that deprive the tumor cells of blood and nutrients. Also, newly approved drugs that are more controversial, but are being currently used are Toracel and Afinitor, which inhibit tumor cell growth and proliferation as well. The drugs are available to patients who fail to respond to the other medications. And then there is this lastly, there's this brand new drug uh, called Votrient, which interferes with the growth of new blood vessels, which supply that tumor with blood and glucose, etc. So that is cool as well. We also can put these patients on immunotherapy to prevent recurrent tumors. Nursing care of the patient is the same for patients that have had a nephrectomy. We just want to monitor them for pain and signs and symptoms of infection and bleeding. Acute renal failure causes, there's a sudden onset with acute renal failure, physical injury, infection, inflammation, or damage from toxic chemicals can cause acute renal failure. Also, renal ischemia can cause acute renal failure. So not having enough blood flow to the kidneys for whatever reason. Circulatory collapse, maybe you've had a myocardial infarction or stroke. Some kind of potentially an aneurysm rupture, right? Severe dehydration can also cause acute renal failure, right? We don't have enough blood flow. We don't have enough fluid coming into the kidney. And prolonged hypotension, so being really, really low for a long period of time, in like incidences of hemorrhage or sepsis. Pathophysiology, you may have pre-renal acute renal failure. This would be indicated by decreased blood flow through like things like hypovolemic shock or decreased cardiac output. You have intrarenal acute renal failure. So this is inside of the kidney itself, like glomerular damage, acute tubular necrosis, caused by ischemia, toxins, or vascular disease. So actual death of the renal cells, right? And then you have post-renal acute renal failure. So this would be due to like an obstruction after the kidneys and the ureter's bladder or urethra. So depending on where the issue is located, it's either pre-renal, intrarenal, or post-renal. Signs and symptoms, changes in urine output and urine, like urinalysis results may indicate acute renal failure. Also, we would see increased BUN or creat. There may be electrolyte imbalances or fluid imbalances where the kidney is not doing its job within the nephron to reabsorb and balance out. Acid-base imbalance may occur as well. We may have GI effects like nausea and vomiting. Mental status changes like confusion, anemia, and platelet dysfunction due to decreased production of erythropoietin. And there may also be impaired wound healing and susceptibility to infection due to acute renal failure. Diagnosis, we'll do a urinalysis, creat, BUN, CBC, electrolytes, and ABGs. Radiologic studies, we could do an ultrasound, IVP, CT, or MRI. And then we also may do a renal biopsy to assist in determining the cause or the extent of kidney damage. We treat by correcting the underlying cause. For example, if you have volume overload, we treat you with diuretics and fluid restrictions. Um, we also want to, if it's an issue with hypovolume, like hypovolemic shock, we want to increase your volume to reperfuse. And we also want to prevent or control complications of acute renal failure. Symptomatic treatment includes correcting the fluid and electrolyte imbalances, managing the anemia and hypertension, hemodialysis or peritoneal dialysis, addressing malnutrition, anemia, and potential for infection as a result of acute renal failure, and continuous renal replacement therapies. Nursing management of acute renal failure, we're going to monitor for signs of fluid imbalance, report urine output of less than 30 milliliters per hour, monitor electrolytes, do a nutritional assessment, encourage optimal activities of daily living, and teach and encourage hand hygiene. So here is a really good concept map for the pathophysiology of renal failure. So acute renal failure, pre-renal or before you get to the kidney, can be caused by shock, CHF, sepsis, anaphylaxis, pulmonary embolism, cardiac tamponade, or renal artery stenosis. So what is happening? There's not enough blood flow to the kidney and therefore not enough oxygen. And this ischemia is going to cause tissue damage. Tissue damage is going to result in a decreased glomerular filtration rate or kidney functioning. Also, we would see a decreased tubular function and decreased hormone secretion as a result, which would result in the inability or decreased ability to excrete fluid, hydrogen, potassium, sodium, nitrogenous wastes, and our phosphorus. So, decreased erythropoietin secretion, decreased vitamin D, and decreased serum calcium may also be seen as a result. Intrarenal causes, nephritis, nephrotoxins, acute glomerulonephritis, vasculitis, acute tubular necrosis, or hepatorenal syndrome can result in the tissue damage, which is going to go through the same cascade. And then post-renal, urethral obstruction, bladder atony, prostatic hyperplasia, urethral stricture, or cervical cancer, something that's causing the inability to release that fluid is going to cause a obstruction and backup of urine with increased pressure, which will cause tissue damage due to ischemia from the pressure. And then we'll see that decreased glomerular filtration rate and so forth. Chronic renal failure can cause things like fluid overload, metabolic acidosis, hyperkalemia, sodium imbalance, azotemia, anemia, or osteodystrophy. So can diminished renal reserve or renal insufficiency seen in end-stage renal disease. Both of these things can cause all of these, but chronic renal failure also causes that tissue damage, right? Which is going to result in that increased glomerular filtration rate and eventually lead to this end-stage renal disease. Phases of acute tubular necrosis, we may see an oliguric or non-oliguric phase. In the oliguric or non-oliguric phase, the patient puts out either a great deal of urine or very little urine, just depending on how their body responds. Oliguria would be 100 to 400 milliliters in 24 hours. The phase would occur immediately or within a week after an ischemic event and would last 10 to 14 days. It can also go on for weeks or months, and prolonged oliguria would worsen the prognosis of the patient. We'll see BUN and creat levels rise, and when this occurs, there may be some fluid volume overload, which can precipitate heart failure as we put a lot of fluid right in circulation. Also, we may see multiple electrolyte imbalances through dilutional, things like hyponatremia. We may have metabolic acidosis or catabolism, or the breakdown of body tissues, and then eventually end-stage renal failure. At this point, dialysis would obviously be needed because the kidneys are not working. And because of the overall decreased kidney functioning related to the aging patient, an older adult may be experiencing oliguria even though their urine volumes are very high, like 600 to 700, right? They're not able to concentrate that urine anyway, so 600 to 700 may be diagnostic as an oliguric phase for the elderly patient. Non-oliguric acute tubular necrosis is often caused by nephrotoxic agents. We see a huge output of urine, but the kidneys are not able to actually eliminate the waste sufficiently. So even though we have a lot of urine being produced, the glomerulus isn't doing its job of filtering. So we have high levels of BUN and creat in the blood. We may have electrolyte imbalances. Dialysis would be needed for this, less often for shorted periods, and the prognosis is a lot better than for oliguric failure. Diuretic phase occurs if dialysis has not been started early and we have extracellular fluid volume buildup. The kidney would be unable to concentrate the urine in this case, and the output may be between 1,000 and 2,000 milliliters per day. With this increased output, there is a huge danger of dehydration, hyponatremia, and hypokalemia. We also may have death related to these electrolyte imbalances or extreme dehydration. 25% of deaths related to acute tubular necrosis are occurring during this diuretic phase. The recovery phase would begin as the kidney function starts to normalize again. The concentration of urine, urinary output, electrolyte balance are going to recover. 1 to 2 weeks of rapid improvement may be noticed, and then a period of slow recovery that's going to take between 3 and 12 months. 1/3 of patients that have been diagnosed with acute tubular necrosis will be left with some type of residual renal insufficiency. And even 5% of those patients may require continued dialysis. So chronic renal failure causes, this is a progressive loss of kidney function. All causes of the acute renal failure could also cause chronic renal failure. Hypertension, diabetes, sickle cell disease, glomerulonephritis, nephrotic syndrome, lupus, heart failure, and liver cirrhosis can also cause chronic renal failure. Healthy People 2020 made a goal to reduce kidney failure due to diabetes through good control of blood glucose, right? Most common causes of chronic renal failure, however, are going to be your glomerulonephritis and your nephrosclerosis. Nephrosclerosis is going to result from high blood pressure levels causing atherosclerotic disease of those small arteries in the kidneys. So there are many stages of chronic renal failure. Know that azotemia is the accumulation of nitrogenous products signaled by an increase in BUN and creat. The patient will be nauseous and vomiting and may have changes in mental awareness and level of consciousness. The kidney's not able to do its job of filtering out those metabolic wastes and also excreting potassium. Therefore, we may have high levels of serum potassium, up to 5 to 7 milliequivalents per liter, which can adversely affect the heart. We know that increased levels of potassium can cause dysrhythmia and cardiac arrest. So that would be very, very dangerous for the patient. There are 3 primary stages of chronic renal failure. In stage 1, there's the diminished renal reserve, but no accumulation of metabolic wastes. Healthier kidney works harder. Urine concentration will be decreased and polyuria and nocturia may occur. In stage 2, we have renal insufficiency. It's signaled by increasing rise in those metabolic wastes. So BUN and serum creat are going to be high. Glomerular filtration rate will fall, so we're not as effective at filtering, and oliguria and edema may occur. And then we have stage 3, which is often considered, they also can sometimes throw in a stage 4 here, but end-stage renal disease. Circulating metabolic wastes are going to accumulate in the blood. We'll be unable to attain homeostasis. Electrolyte and fluid imbalances will become very serious, and we need dialysis or kidney transplant at this point to maintain life. These are some good, this is a good visual for systemic effects of uremia, psychological effects of having high levels of uric acid in the blood can be anxiety or depression, or excuse me, urea in the blood can be anxiety or depression. Cardiovascular, we may see high blood pressure, heart failure, coronary artery disease, pericarditis, or peripheral artery disease. Gastrointestinal system, we may have anorexia, nausea, vomiting, gastrointestinal bleeding, gastritis. Endocrine system or reproductive system, we may have hyperparathyroidism, thyroid abnormalities, amenorrhea, erectile dysfunction. Metabolic, we may have carbohydrate intolerance, hyperlipidemia. Hematologic, we may have anemia or bleeding, potentially even infection. Neurologic, fatigue, headache, sleep disturbances, encephalopathies. Ocular, we may have hypertension retinopathy, like those retinal bleeds, right? Pulmonary system, we may have pulmonary edema, uremic pleuritis, pneumonia. Integumentary, we have pruritus, ecchymosis, or dry scaly skin. Musculoskeletal, we'll see vascular and soft tissue calcifications and osteomalacia, possibly even osteitis fibrosa. And peripheral neuropathy with paresthesias and restless leg syndrome as a potential. So it's very important that we filter out these metabolic wastes in order to prevent these effects of having a buildup in the blood. Signs and symptoms, we may see inability of the kidneys to concentrate urine, so they may have polyuria or nocturia. Renal insufficiency may then occur after the polyuria and nocturia as early signs. We may have oliguria or low output. Eventually, we may have anuria. Uremia or uremic syndrome may occur. We also may have uremic frost. Electrolyte imbalances are bound to occur when we have renal failure with nutritional deficiency as well, and effects from that. Uremia or uremic syndrome includes the clinical signs and symptoms that affect the entire body during end-stage renal disease. Uremia signs generally appear when that BUN goes above 100 milligrams per deciliter. Presence of uremic signs is the absolute indicator for initiating dialysis. If they've got the systemic signs of uremia, we need to get that out of the blood. The goal is to maintain that BUN below 100 and the creatinine below 8 milligrams per deciliter. Well, how do we diagnose this? Well, we look at the creatinine and the creatinine clearance. We may do urinalysis with culture and sensitivity. We may get an H&H, a renal ultrasound, a renal scan, a CT scan, or a renal biopsy. Creatinine is that stable byproduct of skeletal muscle activity. It's excreted completely by the kidneys, and so it's a good indicator of glomerular filtration rate. The creatinine clearance does depend on the amount of blood passing through the kidney. So narrowing of the renal arteriole, shock, or dehydration may decrease that volume that's available for the kidney to filter, and therefore it may be affected by hypovolemia or poor perfusion. Creatinine clearance may also be affected by the functional ability of the glomeruli. So if you have some kind of dysfunction in the glomerulus, you may have that issue. Urine's collected over a 24-hour period to really get a good idea of the creatinine level and clearance. We need to correct fluid and electrolyte imbalances when a person's in chronic renal failure. We want to put them on medications in order to increase their renal function and decrease their fluid retention. They may also get renal dialysis, potentially hemodialysis, which goes through an AV fistula, or peritoneal dialysis, which is done through the abdomen. They might also have a kidney transplant if they make the list and they're a good candidate. Nursing management includes just really encouraging the dietary changes and administering the medications. Dietary changes include decreasing sodium and fat in the diet of those patients that start to have renal insufficiency, and it helps to slow the disease process. Hey, here's a question for you. The nurse is sending the patient to the dialysis clinic. Pre-dialysis nursing interventions would include what? Withholding anticoagulants, administering antihypertensive medications, assessing dialysis access site, checking vital signs, or monitoring lab values. So we're going to withhold those anticoagulants. Why? Because we're going to be accessing their AV fistula, which is an arterial venous formation that's created surgically in order to provide dialysis services. We also want to make sure that the access site looks good and it's got a bruit and a thrill, and therefore is getting blood flow through it, right? It's not been compromised. There's not bruising, bleeding, or swelling that would indicate any kind of perforation or concern at the AV site. We also want to check vital signs to make sure they're within defined limits and monitor those lab values. Peritoneal dialysis. So this is the abdominal dialysis potential. It's done through an abdominal catheter. It helps to exchange fluids, electrolytes, nitrogenous waste is removed. Blood pressure is balanced out, and there's an acid-base balance accomplished as well. The peritoneal membrane acts as the dialyzing membrane, and so we pull that through there. Kidney transplant. So obviously you have to be on the transplant list. You'd have to be a good candidate. What they do is they actually just resect the kidney. So the adrenal gland ends up staying and it hangs out up there. But the diseased kidney is removed. The donor kidney will be cradled inside the iliac fossa so that it could be, because it's not going to be attached to that lining of the abdomen, right? It's not going to be in that attached to the retroperitoneal space either. And therefore it's not going to be able to suspend like the other one previously did. So that donor kidney is cradled down lower. It's sutured in. The renal artery is sutured into the internal iliac artery. The donor renal vein is sutured into the iliac vein. Urinary segments will be sutured in order to connect the kidney to the bladder. And then you see here is an intact kidney. So a kidney that was not resected. You have that kidney. You have the aorta, which gives the renal artery. You have the inferior vena cava, which gives the renal vein. And then down here, you see that we have the iliac artery and vein, which is where we are going to give the blood flow and take the blood away from the kidney. That is a donor site versus straight from the aorta and inferior vena cava higher up. Okay. I think I skipped it. Nursing care of the patient undergoing peritoneal dialysis includes which? Maintaining aseptic technique when accessing the peritoneal catheter, instilling warm dialysates slowly, weighing the patient before and after dialysis, monitoring vital signs, or checking color and volume of your effluent. So, nursing care of the patient that's going through peritoneal dialysis includes maintaining aseptic technique when accessing that catheter, weighing the patient before and after, monitoring vital signs, and checking the color and the volume of what you get out. Okay, guys, that is it for this one. If you have any questions, please let me know.